Welcome to ATCM, the Emergency Medicine Channel. A 41-year-old man came to the ER with complaints of pain in left lower abdomen radiating to the groin. On 10-second initial assessment, airway was patent, no secretions, breathing, respiratory rate was 18 per minute, saturation 98% in room air. Circulation, BP was 120 bar 80 millimeter of mercury, pulse rate was 80 per minute. Patient was having a pain score of around 7/10, so we started on injection TCM. Disability wise, GCS was E4, V5, M6, pupils bilaterally equally reactive, and he was afebrile.
Okay.
Then, sir, on adjuncts to primary survey, so we had asked for an ultrasound, bedside ultrasound, to look for any calculi because patient was complaining from left loin to groin pain. USG was normal, sir, only mild fatty liver was there. So coming to sample history, patient came with complaints of left lower abdomen pain radiating to the groin since that day morning at around 4 am. It was associated with one episode of vomiting. There was no history of any fever, dysuria, decreased urine output, hematuria, or any burning micturition. Patient does not have any previous history of any calculi. After that, we sent for the labs of the patient, and point of care and VBG was taken.
So we have an 41-year-old male who came with what time of the day he came into the ED? That is very important.
Morning 8:30.
Morning 8:30. Okay, morning 8:30, 7:30 he would have come to the, I think it is 7:30 he came to the ED. 7:30 am he came to the ED with an acute lower abdominal pain. Why that is very important? See, this history is very, very classical. So when we have usually, actually when we say we have a time for having dengue fever, leptospirosis, like similarly this possibility of urolithiasis and renal colic, usually they will come in the summer season. That's the usual trend that we have seen in our emergency room. Due to the climate changes, they are coming early in February. And most commonly what you will see, someone is coming like 4 am or something, he would have started this abdominal pain and is coming to the ED maybe around 7 o'clock in the early morning hours. So that is a classical history that you will get, and when you look into the evidences you might not be able to say that this other time, but this is the practice whatever I had seen for the last 15 years, those patients coming to the ED. So a young male 41-year-old coming to the ED with an abdominal pain, possibly with the history, we are pretty sure it's a renal colic. What makes from the history that it is a probably renal colic? What all things are positive to say that this is a renal colic?
So, first of all, sudden onset. Loin to groin radiation is there. So, early morning pain because dehydration, like entire night if they don't drink water, it can precipitate. Then, sir, other than that, no fever. There is no fever.
No fever. Usually, bowel and bowel involvement won't be there. We are thinking into another structure, a colitis or anything else that is producing. Usually, they will have some bowel disturbance. So that is not there. And again, what are the other significant burning micturition? Yes, they can have burning micturition, maybe increased frequency. All those things can be suggestive of a possible renal colic. And hematuria, very important hematuria, painful hematuria. You have painless hematuria and painful hematuria. Painful hematuria, pain with hematuria. Again, all suggestive of, and you can even ask for the history of passing of tiny particles. Maybe the stone would have passed through the urine, maybe partially obstructed. All those things can produce pain. So that is a history that you need to ask on. And what are the key things, what we have the red flags we can say for such an abdominal pain? What all things, okay, I think this is not a urinary colic. So this thing I need to evaluate him. So what are the possible red flags that you need to consider?
So we have to see for the any flank tenderness is there or what? If
So you are thinking in terms of an pyelonephritis. Okay, renal angle tenderness.
Fever. So you have to see for infective markers.
So that is your examination. From the history, what are the possible red flags? One is the age group. Usually when you look into the colic, it is like in the third decade. Third and fourth decade, that's the usual. 30 years and above, a male patient. And maybe female patient, 35, 45 years. That's the usual presentation. And males are more predominant to develop this. And sudden onset, that is again from the history. Loin to groin radiating. Age group is very key. Trauma history. Very important, you have to look in for the trauma history. Any you are thinking in terms of any exertion. We have to one differential diagnosis, as I always say, is a testicular torsion. So that they might just come with a loin to groin pain. So that part also, that is another red flag that you need to consider. Then age group. So suppose the age is above 60 years, there is atherosclerosis. So you need to think whether am I dealing with an aortic emergency, abdominal aortic aneurysm. So that is from the history. But classically, what will happen to the urinary colic pain? It will not resolve. Once you give an analgesic, it will resolve, but it will again come back. So whenever you are getting a history, after a single administration of an analgesic, patient is having a relief of pain, it is mostly unlikely to be a renal colic. So that is one important thing that you can take into. So you are given an analgesic, and after some time again the pain is coming up. It is more in favor of possibility of a renal colic. If it is subsided, you can bring down renal colic much slower down. Usually that will be the pattern. Because why there is a pain in urinary colic? What is the pathophysiology? What happens? Why they are having this colicky sort of an abdominal pain coming and going? So they will have like a waxing and a weaning off period. So when they will have severe pain, and after that it will subside. Some patient might say that I have got mild pain now also. It's not completely resolved. So what is the reason behind the pain?
Sir, due to obstruction, urine can't flow.
Where?
Ureteric obstruction.
There is a ureteric obstruction. So these are the key areas, because anatomically there are 3 areas where the stone can come and get obstructed. And those key area, what will happen? When the stone is coming and obstructing, the urinary flow is obstructed. So proximally there is dilatation. So dilatation, proximally there is dilatation. So as a result, what will happen? There is a lot of prostaglandin synthesis. So again, prostaglandin synthesis will do what? They will increase the diuresis. Okay, so again diuresis increases, there is obstruction, so the pain worsens. So that is how the waxing and weaning sort of a thing will occur, and sometimes the stone will dislodge from that area and comes lower down. When that moving will happen, they can cause small mucosal rent. So that is the reason why you are getting hematuria. So whenever the patient is complaining of this waxing and weaning and not resolving by a single NSAID or whatever be the drug, you can think, okay, am I dealing with a possible renal colic? So that is one thing that in an ER setup that you can think of. So then again, what are the key things? You said pain management is the most important one because it's excruciating pain. So as I said, we commonly go ahead with the WHO triangle. So this is one area where NSAID is a preferred agent over your paracetamol. So if you ask me which is a preferred, you can go ahead with ketorolac. So that will be the preferred regimen. Any NSAIDs for that matter. Only one thing you looking for, the last creatinine. If you are suspecting this is a young chap, you don't have any comorbidities, but maybe in the age of 40-45, chronic diabetes, and you are not very sure, you are seeing some edema and all, already the creatinine is like borderline 1.5, 1.8, don't prefer to use NSAID during that phase. But otherwise, NSAID is the treatment of choice, and opioids will be much lower down. So if it is non-resolving with your NSAIDs, you can think of giving your opioids. It's not a very preferred agent for the management, but very rarely we need to give Fortavin, Phenergan, and maybe higher dose of fentanyl also to keep the patient pain-free. So that is a possibility. So the question arises, patient have come, we have 2 possibilities, whether am I dealing with an ureteric colic or some other differential diagnosis. So some other differential diagnosis, definitely there is a definite role for further evaluation. But even stone, whom all you can dispose of from the ED, whether all patients coming to the ED needs an ultrasound abdomen, needs an X-ray KUB, needs a CT KUB. So that is the next question that need to come. Who all need to be evaluated? So imagine that you are traveling, you are going somewhere and suddenly you develop a ureteric colic and an analgesic has been given, but the pain is not subsiding. Again an analgesic is given, pain have subsided. Imagine that pain, but you need to evaluate that fellow, or you prefer him to send him home with some medications. So who requires evaluation? That is a question. And what investigation? That we all know what, but who requires evaluation?
Patients pain not subsiding on
okay, medication. Requiring more analgesia, pain not subsiding, then
having hematuria with
fever, okay. With any red flags you can go ahead, then reduce your output, definitely yes, then
lamps
past history of similar episode, renal colic, again you can go ahead and evaluate. But otherwise, it's like a borderline decision. Whenever you are taking an ultrasound or an X-ray KUB, majority of the time you are not going to be, you are just buying some time. When this patient comes to here, you are asking for an X-ray or a CT or an ultrasound. Majority of the patient, we are not going to do anything rather than a medical expulsive therapy or what would be the analgesic. But there should be a group of patient where you are very sure you need to evaluate. So maybe depending upon that, maybe a single episode we can leave him, but it's like more than 24 hours. The pain is persisting. Again, after analgesics, the pain is not subsided. And as you said, any evidence of fever, UTI, decrease urine output. So definitely those group you need to increase creatinine. Yes, we need to evaluate. So those group of patient we need to evaluate. Now the question arises: biochemical investigation, urine evaluation. We all know creatinine is what we need to assess. And before that, we'll go on. What are the imaging modalities that you wanted? So, what is the best investigation of choice?
Investigation of choice is CTKUB. But
CTKUB, 7,500 rupees. You can totally manage and
X-ray with ultrasound, we can do investigation of choice.
Investigation of choice, okay, fine, I agree with that. But you cannot don't go and say poor fellow who has been traveling, his monthly salary will be 1 CT's money. So don't go ahead and jump and CTKUB. You have to discuss with the family and what additional information that you are going to get. See, what I will suggest is maybe you go ahead with an X-ray KUB, basic X-ray KUB, and ultrasound is reasonable during that time. And you compare both the modalities together. With ultrasound and KUB, you can combine and see how much you are able to get the access. Suppose in ultrasound, what additional information that you will get in CTKB, exactly the position of the stone, the size of the stone, that's it. Ultrasound, if you have good radiologists who can help you in it, you can get all this information. So key information what I wanted in ultrasound is that whether there is any gross hydronephrosis. That's the only information that I wanted. If there is a gross hydronephrosis, if I am unable to identify a stone in the ultrasound and in the X-ray, and there is a raised creatinine. So that patient you definitely needs a CTKUB. So that we have to go ahead. Or otherwise you have an other diagnosis in your mind. You are not very sure. Ultrasound also is not giving you a clear answer, but you are having some other differential diagnosis in your mind. Then CT you can do. But routinely CTKUB, maybe you will get an when you ask pulmonary embolism what is the investigation, this is CT pulmonary angiogram. That is a life-threatening condition. But urinary colic is not a life-threatening condition. You can always have by some time by doing other investigation. But certain people, they will be more happy to go ahead and do straight away CTKUB. That's fine. But these are the two things that you need to do. And blood investigation, creatinine. And what are the other investigations that you wanted to send?
Uric acid.
Uric acid.
Serum calcium.
Serum calcium.
Serum sodium also.
Serum sodium, okay, fine. Okay.
Then CBC, CRP,
okay.
UTI symptoms are urinary.
My question will be, what are the anatomical predisposition for one person to develop an urinary calculi? What are the anatomical problems?
Medullary sponge kidney for patients.
Okay, horseshoe kidney, medullary kidney, vesico-urethric reflux, all those things are predominantly they have a high chance of developing this ureteric stone. Then when we come to medical reasons, who all group of patient, biochemical, as you said, hypercalciuria, hyperoxaluria, and all those things are prone to develop this renal stones. Then which group of patients they are more prone? You can read it out, no problem.
No, sir, the major risk factors are anatomically it will be medullary sponge kidney, horseshoe kidney. Then regarding diet, patients who take lower fluid intake, those who have lower dietary calcium, higher oxalate content, then sir, high sucrose and fructose containing diet, high vitamin C supplements those who keep taking. Then patients having primary hyperthyroidism, gout, obesity. Diabetes, distal renal tubular acidosis or inflammatory bowel.
What drug that you wanted to check in the drug list if a patient is coming with some history, and which drug that you wanted to see when he developing a stone? You see that, no problem. It is written, you see that.
No, it's not. So I've studied. Forgot. It's not written.
Thiazide diuretics.
Diuretics will stop.
Thiazide diuretics will increase the uric acid. It will. When you are having a patient on gout, you will not prefer to give thiazide diuretics. So thiazide diuretics can increase the uric acid, and as a result, uric acid stones can form. But that is a very small proportion of patient, because majority of the time you are having calcium oxalate crystals, calcium stones. Uric acid stone is a very bare minimum. Then what are the other drugs that can precipitate a renal stone? In the that's not been used these days. So most commonly these are the xanthine oxidase inhibitors. All those drugs are the common one. But we are not using these drugs these days. Only thing, hydrochlorothiazide is one drug that you can look in for. Why? Not directly, it can increase uric acid, which can indirectly increase the uric stone formation also. So when you have gout, don't prescribe thiazide diuretics. So that is the take-home message. Then another thing, urine examination. So urine routine examination, 30 rupees investigation. How it is going to help you in managing of a renal stone?
Sir,
What all information that you are going to get?
so first of all, we can check for the bacteria and pustules if UTI is there.
Okay.
Then hematuria. If blood.
My question is that if seeing a lot of bacteria, a lot of pustules in a patient with renal stones, so how will you approach that?
UTI with renal cancer.
Patient don't have any fever, no chills and rigor, no tenderness, anything. You will treat it as a UTI. Unlikely, I will not treat it as a UTI, but you have to see clinical judgment also. Maybe like very minimal pustules, we can leave it alone. Maybe like 10 to 20%, yes, we can think of it. Maybe a structural, he has having recurrent UTI. That itself can predispose to stone formation.
Yes.
So you have to think that way. So recurrent UTI causing and stone formation. Then,
We'll also look for the pH, alkaline or acidic.
Okay.
pH. Then other than that,
Stones.
Stones. How it,
stones. That is the most important. No, calcium oxalate, all those
Calcium
crystals.
oxalate,
Whatever we have learned in our biochemistry, looking into the crystal, that is the most important investigation that we are looking in for. So something you are seeing crystals and you are already seeing all those things, then we are sure what we are dealing with. Hematuria, microscopic hematuria. Majority of the patient you look into that urine routine, they will have some amount of microscopic hematuria. So these all things will give you a clue that probably the patient is having a renal colic. Now you decided these are the investigation that we have done. Then ultrasound I said and CT KUB. Now the pain have subsided. Okay, CT KUB you have taken and you are seeing a stone of this many, whatever be the size. So the patient is asking, I am pain free now, can I go home? So whom all you will ask them to be admitted, or whom all patients you can discharge?
So, this size of the stone we'll get to know from the CT.
Okay, CT I am telling it is 6 mm stone.
So, 5 to 10 mm stone, if it's present, we can try medically expensive therapy. And we can discharge with that, and we can continue it for 2 to 4 weeks. If patient is not
What is medical expulsion therapy?
So we can start the patient on alpha blockers like tamsulosin, alphazocin. We can
There are two schools of thought. Some urologists are for it, some are not for it. But it is what we found. It is effective medical expulsive therapy. An alpha blocker with a small dose of steroid can decrease the inflammation and it can help in removal of the stone. And the patient is much symptomatically much better.
So we can start for 2 to 4 weeks and ask the patient if there is, look for any stone in the urine. Staining of urine has to be done. And also if pain doesn't recur, then it's fine. But if recurs, then patient has to come back and urology consult has to be seen.
Okay.
And we can also start for steroids. We can say short term if edema is seen in the CTKU.
Okay.
Short term 3 days steroids we can give.
Antibiotics required?
So if no infection.
No infection, routinely not indicated as such. Then,
Other than that, if we are suspecting, like the etiology, if we are suspecting, if uric acid, if we are suspecting it's, if it was the higher range, we can start on any anti-gout measures, like we can start on febuxostat.
and what advice you will give to the patient?
Also diet, here they have to stop taking red meat, if they limit red meat, and some wheat bran and some vegetables.
Most commonly, what is the problem? 41-year-old, he has come,
Alcohol.
and you said mild fatty liver.
Alcohol, sir.
It's alcohol. And the classical history that you might get, you might be that is a group of patients, they had a binge 2 days or overnight, they have taken a lot of, consumed a lot of beer, that itself can increase diuresis. So they can come with pain. So that is one history that we had seen when we go and ask them, that history used to be positive. Then, so can he, so you think that this patient can go home? So whom all you need to admit that?
So large stones more than 10 millimeter have to undergo any surgical procedure for extraction of stones.
Okay.
Then patients with fever, with worsening creat, decrease in urine output. Patients have, if any metabolic acidosis develops, then
That definitely
AKI,
you will not send home, no.
That patients
I'm
have
just
to be
sending you
admitted.
a renal colic patient whom all you need to admit, a hydronephrosis.
With hydronephrosis.
Hydronephrosis, when you are seeing an hydronephrosis, he need to be admitted. So there is a possibility his creatinine can go up and there can be a further worsening. So, and there is a possibility that the stone can propel off by itself also, and more than 10 mm definitely to be admitted. Pain not subsiding by initial management. That is again very important. You are given all your analgesics, still the pain is not subsiding. It is not fair to send him home because he might require another analgesics. So then, any source of, we are suspecting an pyelonephritis or any infection, he need to be, not any infection I will say, maybe pyelonephritis, maybe a mild UTI you are suspecting, you can discharge him with oral medication. Then his underlying comorbidities. He have got any other underlying comorbidities that is hindering the treatment of this. Like we cannot give more of like an NSAID. Already there is a creatinine is high, but even if 5 mm stone, but you can't go ahead and give NSAIDs for him. So he requires maybe the normal therapy won't be sufficient. So that group of patients is a grey area. So rest all patients you can send them home safely and by prescribing all these medications, and definitely they should be followed up. And if possible, you need to tell them to. Sometimes the stone will get expelled, and if they are bringing back the stone, we can give to the biochemistry lab, and we can see what exactly is the reason behind why they have developed. So, an ultrasound, CT. This is what you have to take the decisions. Okay. So, what has happened to this patient?
So, patient on doing the CT QB, we found 3.
So, what is the reason behind we asked for a CT KSB? That is my question.
Because ultrasound showed nothing, but patient was having persisting
Ultrasound
pain.
was inconclusive. So, that is the reason we went ahead with the CT. Okay. But history wise, it was classical that he was having a renal colic. So, why the ultrasound was inconclusive? User dependence. So, ultrasound is an investigation. It's a user variability can happen. So, to say it was not the same quality, it all depends upon the person who is doing the scan also. Then.
Patient is still having pain after giving, after PCM we give injection cyclopam. After that it decreased, but again patient complained of severe pain, now more in the flank side. It was initially lower abdomen, flank side we had to give tramadol, but it was short lived. After that patient did not complain of pain. We took a CT KUB, it showed a 3.4 into 2.7 millimeter left sided VUJ calculi. After that, so we had sent for the routine labs. His uric acid came out to be 6.3. There were no infective markers. Total counts were 10,000. CRP was 2 only. Uric acid was 6.3. Calcium was 9. Since on the higher side, uric acid is on the higher side, we discharged him. Urology consult was sought for the patient, and after that, there was no intervention needed from their side. We started him on alphozocin 10 milligram. At night, and we gave cyclopam SOS, and we discharged with febuxostat 40 milligram.
Okay. What are the treatment options for a complicated renal stone? As I said, there is hydronephrosis, like more than 10-15 mm. What are the treatment options available for us?
So we can go with a shockwave lithotripsy, then ureteroscopy.
Immediately do we go for a shockwave lithotripsy?
DJ stenting. First, ureteroscopic stenting is there. And then we, one of the modalities is shockwave lithotripsy. Then another modality is percutaneous nephrolithostomy.
Percutaneous nephrolithostomy will be the last resort when you have a large, maybe a staghorn calculi, a huge staghorn calculi that is obstructing in the kidney and pelvis, renal pelvis, and there is no output. And one more person that I will not discharge is who is having a solitary kidney. Again, who is having a solitary kidney. What will be the size of the stone? I didn't mention. Who is having a solitary kidney, I would never like him to go home. Okay. So, he's okay right now and discharged. Okay. So, in a nutshell, in the ED, what you need to understand, what are the differential diagnoses? What are the key things that you need to consider when it's a renal colic? The classical thing, whatever NSAIDs that you are giving, the pain not subsided. Again and again, it's coming. And remember, other red flags. What are the other common issues that the patient can have? And it might not be a renal colic as such. It might be some intestinal or a vascular pathology, which we can miss, even a testicular torsion. Look.